Okay, I'll go ahead and get started today. Very excited to be speaking about this important topic in our society. My name is Eric Weaver. I am the Executive Director of the Accountable Care Learning Collaborative. And I'll be serving as the moderator today. And our virtual panel discussion includes Dr. Ernest Grant, President of the American Nurses Association, Dr. Jan Jones-Schenk, Senior Vice President, College of Health Professions for WGU, and Jason Thompson, Vice President, Diversity, Equity, and Inclusion for WGU. And they are going to provide their thought leadership to really advance solutions for how we promote health equity and reduce racial disparities in care through transformation of the nursing workforce. Before we get started today, I wanted to provide some reference to population health research that shows us that the American healthcare system is not immune to institutional racial discrimination. African-American patients tend to receive lower quality healthcare, including treatments for cancer, HIV, prenatal care, diabetes, and preventative care. They are also less likely to receive treatment for cardiovascular disease, and they are more likely to have unnecessary limb amputations. African-American men, in particular, have the worst health outcomes of any major demographic group in our country. And health disparities also affect African-American women, leading to increased death rates from breast cancer, threefold risk of dying during pregnancy, and significantly greater chance of dying needlessly from preventable disease. In this current pandemic, communities of color are also being disproportionately hit hard by COVID-19 due to inadequate access to testing in African-American neighborhoods. And for those likely to obtain testing, there's a much higher death rate. 3 times more likely are African-Americans in facing death due to COVID-19, which further illustrates inequities within our healthcare system. So needless to say, research has been irrefutably able to show that if you control for all the variables that contribute to health disparities, education, income, access to health insurance, African Americans still get the worst quality of healthcare of any demographic in our country. And in recognition of this institutional discrimination that we have to overcome, I want us today to engage our panel in discussion about how can we care for patients in a more culturally competent way, specifically with regard to the nursing workforce, so we can mirror the unique cultural characteristics of our population. As we consider racial disparities in our conversation today, I want us to also think about higher education and the role that it plays in partnering with the healthcare industry to establish a nursing workforce for tomorrow. The continuance of systematic racism and privilege granted to white people in America must be addressed if we are to achieve true population health and parity and outcomes for all. So for today's first question for our panel, I wanted to start the conversation and really open up the conversation on race in our country. And Jason, I wanted to address this question to you. I want to, as we as a society start having a conversation identifying structural racism in healthcare or any other institution, how do we open up a conversation? When it comes to recognizing systemic racism, it seems like we have this really big challenge in getting universal recognition that it even exists. For example, for those that resent the Black Lives Matter movement, they may say all lives matter. Or in the incidents that we see of nursing while Black, someone may say, oh, they're just using the race card. So how can we engage society in a conversation to foster a better understanding about the presence of racism in our society?
Yeah, that's a complicated question. And you cited some pretty incredible, data that's sad, to say the least. And I think the work here is we have to continue to bring up the issue and continue to engage. I think many times people want this simple answer, but I always use the analogy that, I do a lot of diversity training, and I tell people, I can't make you racist in 45 minutes, and I can't undo it in 45 minutes, that it takes a lot of conversations. And, I look back at my own, views of the world. And when I was in college, I was horribly homophobic. That view has changed over the years, partly because of information that's shared with me, my own desire to learn and be a better person. So my recommendation would, we have to continue to have this conversation and realize that, it takes that constant engagement, and that there isn't a simple answer. These things take time. I take faith in the fact that people keep bringing it up. These kind of sessions are helpful, and that if all of us continue to engage, we can, move the needle. It unfortunately is going to happen quick. I mean, that's probably the biggest challenge here, is that for many of these challenges, especially within the healthcare, are urgent. We need to move quicker, but we have to keep having the conversation and not lose hope. I think that's going to be our biggest challenges. Many times it feels like nothing's changed. People don't want to engage, but we have to continue to do that and realize that for many times we have to keep having the conversation, and that is a solution.
Absolutely. We must have the conversation. And I think we have to also think about the role that the nursing profession plays in really creating a sense of activism in our industry. There's never been a period in American history where the health of Blacks has been equal to the health of whites. It just does not. There's no period in time where that exists, where you have that parity. It seems like disparity is built into the system, and routine medical practice continues to treat Black and white Americans differently. And this must be changed if we're truly to transform our healthcare system and improve outcomes for all. Advancing health equity is going to require a justice-oriented framework where we really have to identify structural racism and its manifestation in medical care, and then dismantle the grasp that it has on pre-existing health systems. And that may require us to incentivize disparities reduction, through value-based payment models and other ways to engineer the new healthcare system of tomorrow. I wanted to ask the panel today, I was reading an article last June. It was in JAMA, and it was written by Donald Berwick. And it was called The Moral Determinants of Health. And he proposed some really what some may say are radical ideas about how to create a justice-oriented framework for the healthcare industry. He called for this moral force to happen in professional leadership in healthcare, where you can mobilize around this issue of social justice. And he posited for the health professions to really play an outspoken role in determining social conditions, countering inequity, and really fighting against structural racism. And, Dr. Grant, I know the ANA has a similar position, calling for the nursing profession really to speak out, to opposition, and really tying in that position statement to the values and the ethical code of the nursing profession, which really directs nurses to respect the inherent dignity, worth, and unique attributes that are a part of the human rights of all individuals. So, Dr. Grant, I wanted to pose this question to you. How should the nursing profession mobilize around this important issue of institutional racism and health disparities? And then what would you say to those that want the nursing profession just to stay focused on caring for the ill instead of really demanding and supporting societal reform?
Well, thank you very much, Eric. And I'll answer the first part of your question first. Just to sort of tag on with what you had first asked of Jason, events around the country that are happening today tend to be a very stark reminder when we look at, that COVID-19 is not the only pandemic that Americans are facing. Again, just referencing back to the data that you presented about African Americans and healthcare and the disparity that they receive. We know that racism is a long-standing public health crisis that impacts not only the mental, but spiritual and physical health. And, COVID-19 obviously is just exacerbating this crisis right now and adding stress to the Black community and other communities of color, which are experiencing obviously just higher rates of infections and death. But I think the underlying factors that drive this is the disproportionate burden of disease on the social determinants of health, meaning that the social and the economic factors that contribute to poor access to healthcare or poor health status, including incidents of chronic disease like diabetes and hypertension. So I think the way the nursing profession mobilize around this important issue is that it is part of who we are as nurses to call attention to that. Obviously, we try to promote health, and health means not necessarily just applying in the acute care setting, in the hospital. It is also outside of the hospital as well. And I had the opportunity back in May to have a discussion with the House Committee on Ways and Means on the disparate impact of COVID-19 on these communities of color. And we shared some recommendations that were specifically related to COVID-19 and to address some of the longstanding issues of racial disparities, such as the crisis in the maternal mortality and basic access to healthcare, including the mental health services. And I think to answer the second part of your question about what to say to those who want the nursing profession to stay focused on caring for the ill instead of demanding, supporting social reform, we have, as nurses, we have a responsibility to use our voice to call for change. Our code of ethics obligates us as nurses to be allies and to advocate and speak up against racism, discrimination, and injustice. And we are not truly fulfilling that or following our code of ethics when we're expected to just only treat in the acute care setting and forget about what else is going on. We want to promote health and wellness so that people don't wind up in the acute care setting. So it's sort of a double-edged sword, if you will, that nurses have to do. But primarily, we want to focus mainly on prevention and good health care, before the individual winds up in the acute care setting or long-term care setting, when there's so much more that we can do in the preventive forms of that. So I'll leave it at that, or perhaps have some more dialogue if necessary.
I would love to hear from you as well, Dr. Jones-Schenk. What would you say to someone that says, nurses just need to practice and do their job and care for patients, and then they need to stay out of the political arena? There's no place for that in the profession.
Thank you, Eric and Dr. Grant. I think the important consideration here that I'd like to add is that we as nurses need to go upstream to the source. So continuing to think about our practice as illness-based versus finding the source of the illness, the source of the problem, and going upstream to seek those solutions. So that's really where the societal reform comes into play. It's very much like what we've talked about in healthcare over the last couple of years in regards to value-based care, in the sense that we are trying to bend the cost curve by going upstream, and that means early intervention, that means prevention, that means engaging clients and families earlier in their health management process to secure and obtain better health outcomes for them downstream. The same is true here in regard to societal reform. As a profession, we make a promise to society that we will serve the health needs of society. And in this case, those health needs and the imperative really is very clear to us that we are not doing all that we need to do for diverse populations, and we're not achieving the outcomes. So we have a responsibility for outcomes, not just for caring for illness in the moment.
I want to stay on this topic of value-based healthcare, and Jan, you bring up some great points. And so many leaders in the healthcare industry, they look at that value equation and better outcomes, lower costs, better patient experience, and they don't think of outcomes in terms of addressing disparities. They almost want to apply a blanket strategy. Well, let's address the chronically ill. But they don't really take into account the cultural nuance and the importance of really delivering care that truly meets the needs of the population and in a culturally relevant way. And there was as value-based care has emerged over the last 2 decades, I really think the impact on racial health disparities has been limited. And there was a great article last month in Health Affairs, and it was called "Value-Based Healthcare Must Value Black Lives." And it was interesting. This article proposed a framework for how to incorporate racial justice into value-based healthcare, which included the re-engineering of pay-for-performance models that include health equity as a financial measure for success. And even with the realignment of financial incentives over time, it still proves difficult to counteract the structural racism and policies. And it's something that we may not even be aware exists, but it's there. And it results in poor social determinants of health, and really health inequity. So Dr. Grant, I'll pose this question for you to start off with. How can we as a country build the economic will to reorient the value-based care policies around racial and health justice? And what role does the nursing profession play in advocating for this change within value-based care payment models? Just as much as nursing programs are integrating value-based care into its curriculum, how can we also hardwire conformance to social justice within the nursing profession?
Well, first, I think we must be the change that we want to see in our workplace and in our community. So, so as nurses, we start that change, and of course, we're able to get other thought leaders, people who are looking at value-based care and et cetera, to begin to adopt what we're wanting to see. One of the first priorities that I set as president, as ANA president, was to promote efforts that would increase the diversity of nursing, and ANA is committed to implementing comprehensive strategies to address these inequities. But again, we must start early to eradicate a lot of the stereotypes. One of the things that I do, I go into elementary schools, and that's where it needs to start for perhaps for someone who wants to consider nursing as a career or whatever. I go in, work with a fourth grade class. The audience may not realize this, but I am 6'5". So when you're going into a elementary school, and you're talking to young kids about considering nursing as a career, if they see the 6'5" black guy there, who knows, there may be a young black boy or Hispanic boy, or even a white boy who probably never thought about nursing, but perhaps in their mind they're thinking, well, if he can do it, why can't I? And we begin to see that there. So we begin to eradicate those stereotypes that may be there. Also, we aim for, ANA itself, we aim for a nursing workforce to be equally representative of the diverse population that we serve. So there it comes to the nursing schools being able to admit more people of color and from different cultures, and to embrace from there as well. It also means doing some of the other fundamental change, such as the textbooks that we have, the way that they begin to address what they think may be cultural, but it really doesn't. It lumps people into a certain category, and because we don't fit that stereotype, we begin to create some complications, so to speak, or the way that conformance, so to speak, to social justice within the profession that way. So we have to look at remodeling our textbooks and how they begin to address things. And then I think within the profession itself, having leadership academies or mentorship program. I know ANA has, we have a great mentorship program that actually the first time last year, I think we had a little over 9,000 people to participate in that. And it's mentorship from the beginning, from the novice nurse all the way through to the seasoned nurse who's going to perhaps go into positions of leadership. They too, even though they're recognized as a leader, if they're just becoming a manager or even going into the C-suite, they still need to be mentored as to how they can begin to set the example of change along those ways. And implementing a system of check and balances within the hospital systems. I've always have said that hospitals and long-term care facilities should take a look at the makeup of their boards or of their administration and their leadership, and see, does it reflect the people that you're caring for as well? Those are some of the ways that we can go about getting these changes underway. It is going to take a while to get it done, but that is certainly some of the ways that we can begin to do that.
It's a great response, Dr. Grant. And I wanted to ask Dr. Jones-Schenk some follow-up on this important issue of value-based care. Again, revisiting the term value-based care, it's become, kind of embedded in the healthcare lexicon over the last couple of decades. And we've had a couple of iterations, accountable care and so forth, but it's really based on the economic imperative first and foremost, at least in the industry's mind, that, we have to lower costs. The per capita spend is way too much. We're more than twice as the second, industrialized country in healthcare spend. But, given that there is an economic imperative, we all realize it. How do we lead a social movement towards health equity that is based on the moral imperative? How do we hardwire that into nursing to where we're thinking about that every day a nurse steps into work, like what they can do and have some sense of intentionality? I'm very interested, and Jason, I'd love for you to join in this as well, just thinking about just in the terms of moving the industry, moving society. How do we align, both of these efforts in terms of cost reduction and better outcomes, but also have the societal focus that we have to do what's right for all populations and address these important disparities?
Yeah, it's really a great point, Eric. And I think part of what we're fighting against is sort of the historical tyranny of the aggregate. So we aggregate all of our data, and we typically have not been as focused on stratifying data by populations. So with regard to your earlier comment where, the outcomes data that are driving reimbursements, for example, in value-based care may not be specific enough to the health equity issues that could be explored and exposed by a deeper analysis of population-specific data. So population health strategies are really critical here. They need to be a part of nursing education, and we need to align these scientific approaches with the concepts of social justice. So if you're not able to see, once you see where there is inequity, then you can do something about it, and you have the opportunity to practice in ways that are more just and more equitable. Another example I would just say is that even in our research, and I've been reading a lot about the research that's being done, the trials that are being done on the vaccines, and the extent to which diverse populations are being included in that research, or perhaps they're being included, but the research analysis is not fully stratified by population. That's a weakness for our entire system. And so we need to make sure that in our curricula, in our preparation of all health professionals, especially nurses, that they're thinking about these kinds of important elements that are both science and social justice. These are married concepts. I think we also need to make sure that our environments, back to what Dr. Grant was saying, there's an identification of role and personal type that occurs. He talked about going and talking to young people in middle schools and in elementary schools. And when our faculty are not diverse and our faculty do not represent the diversity of our population, then we lose out on attracting people to nursing because they don't see themselves in nursing. They're not in our faculty. The visibility of people who come from similar backgrounds, who look similar, who have similar cultural or origins. If we don't do that, if we don't create those environments through our faculty recruitment and development, then we are perpetuating this problem.
I want to stay on this point on visibility and nursing leadership and thinking about this social movement. I reflect back, and as I was preparing for the panel discussion today, I found the Institute of Medicine's report entitled "The Future of Nursing: Leading Change and Advancing Health." It came out 10 years ago to the day, like with this conversation right now. So we're 10 years past the issuance of this report, and in that report, it made clear in one of the recommendations that nurses must have an increased number of seats on boards. They must be in decision-making roles. They must be moving the healthcare industry towards health equity and providing better outcomes for all. And there was this goal that was stated in the report. It was called the, I think it was a goal of having 10,000 nurses on boards by 2020, which is right now. Really what the report was seeking to do in its recommendation was incorporating the unique perspective of nurses to achieve the goals of improved societal health outcomes. So I wanted to stay on this for a couple of questions, and I have some specific questions on nursing leadership, but I wanted to ask you first, Jason. As companies are diversifying their boards and their C-suite, what will it take for organizations to make strides in addressing the underrepresentation of women, minorities, and nurses on corporate boards and senior leadership roles? And how is this different than maybe some that would say, oh, this is just affirmative action and meeting a quota? Like, how do we seriously get to a point where we're recognizing there's a problem, we need to fix it, and here's a solution?
Yeah, I think we're at the point now where we have to just be honest about what's happening. If you're not intentional, you can't undo it. When we wanted to integrate schools, we just took Black children and white children and put them in different schools. We had to. That's how it works. This board issue is the same. We have to be unafraid about, call it a quota, call it whatever you want. But if we don't become intentional, we're going to keep seeing the same problem. And, there's a weird kind of equation here. If you think about it, we treat Black people poorly and it actually costs us more. Mm-hmm. And what's been said is kind of interesting because Black people aren't a significant number. They don't represent a lot of people in the healthcare system, right? So in theory, it's covered up, but it's more expensive. So the small percentage of people come into the healthcare system, we treat them poorly, but because we aggregate our data and we don't look by race, it's lost in that. And we think, oh, we're profitable. When in fact, we could actually be more profitable by treating Black people better. There's an equation here that we should be honest about and intentional. And if we're going to talk about our boards, we have to do the same thing. Or in our leadership team, we have to be intentional, look at our data and say, this data is embarrassing. This is actually statistically impossible for us to be in a situation where women make up a significant amount of healthcare providers, but we don't see them on the board. How's that even possible? Mm-hmm. And because it is possible and we're doing this, the only way to undo it is say, we got to have this uncomfortable conversation, talk about race, talk about gender, and look at this board and say, this is mathematically impossible for us to keep getting this outcome. And to undo it, we have to be intentional. We have to say things that make people uncomfortable, and we can be unapologetic because we are about solutions. And I think the more we can focus on the solution and where we want to go, the better we are to get there. And the data supports that this is something we could do. If we're really about saving money and being efficient and providing better care, let's call it out for what it is. And just as an aside, I think one of the challenges we have right now is we call it health disparities. And when I think of the term health disparities, that's something that's outside of me. I don't control that. If I say this is racist, that feels like me. And then I need to look at myself and what behavior do we have? And I think we do need to talk about this as racism, not about health disparities, because that feels like it's not me. And we have to use terms that make people feel like, yeah, that is me, that I have a responsibility in this. And so those would be my suggestions and recommendations is we got to get uncomfortable and stay in that uncomfortable space.
It's a great point, Jason, and I really appreciate the comments there. And I think you make you're spot on. We have to identify it and call it out for what it is. There is racism. It's institutionalized. It exists. We need to overcome it. And I think in going back to the kind of the spirit of the IOM Future of Nursing report, there was this call to action. We've got to get nurses in leadership. And I wanted to ask Dr. Jones-Schenk and Dr. Grant here. First, have we seen the leadership and empowerment of nurses improve over the last decade? And then to Jason's point, if there is this sense of empowerment, can they begin to redefine the terms of engagement here where we're really calling out, institutional racism for what it is, where we can get past, health disparities and some of the more nuanced language, which may seemingly marginalize, this problem and not really elevate it to the level of importance where it really is in our society?
Yeah, Eric, I'll just chime in really quickly here. I remember when the Future of Nursing report came out, and it was a groundbreaking report. It crashed the IOM site multiple times as people were trying to download this. A number of recommendations that have been dramatic in changing the way we've looked and worked towards transforming the nursing workforce. But I also remember when this particular element about nurses on boards was being discussed, and 10,000 nurses on boards. Wow, that just sounded like a moonshot, right? That was just this enormous target. It's less than 0.03% of nurses in the country. When you look at over 3 million nurses, 10,000 isn't very many. But at the time, 10 years ago, it was a moonshot. And so I think what they've done, we were really proud as WGU College of Health to be one of the original sponsors of this initiative. And we've seen a significant number of our faculty and alumni join the database and achieve board appointments. I think the last data I saw was maybe in August. There were, the national target was over 7,500 nurses on boards. And it's increased, it's continued to increase. So how did they do it? They did it because they understood the imbalances, they called out the imbalances, they set a goal, they created a supportive structure of education, interest, recruitment, management of data, communication around the goal, and that's how they did it. So it's as Jason, I think, pointed out, language matters. Language is really important. And sometimes we use softened language because we don't want to hurt people's feelings. Well, we're hurting far more than people's feelings right now by using overly nuanced language to describe this problem. We need to set that aside, and we need to be more direct. And then we need to go beyond the identification of the problem into the real structural problem solving strategies. Nurses on Boards gives us an exemplar. There are many others around the country, exemplars for how you solve these kinds of imbalances. So it can be done. I think once we agree that we will do these things.
I'd also would just like to add to what Dr. Jones-Schenk has said. Well, currently, I think the last number that I saw, it was 7,950 nurses who are on boards. And the whole idea behind this is that, and it's not just boards of of healthcare systems, whereas we can definitely make a significant impact there as well. But when you take the social determinants of health, all those 17 or 18 different identified things that can be addressed there, having a nurse to become involved within the community and serving on boards, such as maybe the school board or, the local town council, or, or serving as an advisory capacity or whatever. This is what is driving change as well, so that we can improve health and the efficiency of health and access to healthcare by doing that. So again, it sort of just relates back to your question earlier about what do you say to people who think that nurses should just remain at the bedside in the acute care setting? Nurses are everywhere, and this is this is a prime example of because we are the most trusted profession. You get a nurse who is standing up and challenging people of the town council that, we need to improve water here, or we've got a situation here where there's lack of access to proper food. All you have is a Dollar General store that, people are going in to buy their groceries. And we know that the food that may be sold in that store, and this is not to put down Dollar General in no way, but a lot of that food is high in sodium and et cetera. So when you got a community that may have, high diabetes or heart problems and et cetera, they don't need to be going there. They need to be going to a grocery store that can provide them with fresh fruits and vegetables that they can, have a healthy diet. So this is how having nurses on boards is going to make a significant difference, is not only in the healthcare setting, but also out in the community, so that, again, there's improvement of health all the way around. And I'm proud to say also that, ANA is also a member of this, of this drive, and will continue to have much more success with this. We've only got 2 more months left in this campaign, but it's not just going to end at 2020. We're going to continue to carry it on as we get more and more nurses to also consider to run for legislative offices. Even at the state level, they're going to be able to make a difference because they know, they have been there, they understand, and now they can influence legislation that can also make lives a little bit easier also and address these health disparities.
If I could add one more thing, Dr. Grant, you made me think of a great story and I have to share it. Recently, we heard from one of our faculty members about a student in our RN to BSN program who had, through the course of his community and population health course, had done a number of assessments in his community. That's part of the curriculum, is to do these assessments. And he became very, I would say, first of all, disappointed and then inspired by the things that he could do in his own community, the gaps that he saw. So he went and met with the mayor of his small town and said, there are all these things we need. We need mobile mammography. We need Narcotics Anonymous. We have a big opioid addiction problem in our community. We need a suicide prevention line. He was talking with the mayor and the mayor said, hey, that's not my business. That's not the business of running this town. We're not going to do any of those things. So this student ran for mayor and he won. And unfortunately, sadly, his opponent died during the campaign of diabetes-associated complications. So the story just, it just so illustrates that healthcare is local and it's where you live, it's where you work. And seeing yourself as a nurse, as someone who can make a difference in your own community is a contribution that is, I would say, beyond ways that we've thought about our practice traditionally and historically. Well, I have to say Florence always thought that way, but that story really, I thought, brought it all home.
Yes, it does.
I have to say, one of the things I've learned over the last couple of years, which I think still our society really hasn't faced head on, is that if we create diversity in the nursing workforce with regard to gender and age and ethnicity and sexual orientation, we can impact disparities in care. We can overcome racism. And there was, and just in my research, kind of thinking about our discussion today, I found a really strong and compelling statement, and it came out of a report that was released in 2004. It was called Missing Persons, Minorities in the Health Professions. And I want to read this quote just because it really resonated with me deeply. It said, "The fact that the nation's health professions have not kept pace with changing demographics may be an even greater cause of disparities in health access and outcomes than the persistent lack of health insurance for tens of millions of Americans." And when I read that, I was like, oh my gosh, that is so powerful. It's true. And then so if you look at the composition of the nursing workforce right now, you have 81% of nurses that are white, 19% are from underrepresented racial and ethnic populations. And to this day, still, African Americans and Hispanics are still grossly underrepresented in the RN ranks compared to the general population. And of course, the male, gender itself, is, as we all know, is underrepresented. I think it's about 7% of the workforce. So, Jason, I wanted to ask you this question here. How can you provide your perspective on how organizations should be aiming towards nursing workforce diversification and really approach it with a quantifiable strategic plan? And it's not, and I want you to expand upon it a little bit more than that. It's not just quantifying goals, reaching a quota, checking a box, but then how can you actually raise the conversation to the level that it's uncomfortable within the organization that we have to do this to improve patient outcomes? And then I also want you to somehow address, this issue that we're seeing just with, creating awareness and being able to really overcome this and cascading that out through the entire healthcare industry. I'd love to hear your perspective on this, Jason.
Yeah, this is something that often comes up, and I actually worked in a health science center as well as in a hospital system. And it was, we always had this issue in conversation. And I think one of our challenges, we tend to work in silos. And what I mean by that is at the high school level, we're not really having a conversation about health professions. And even at the collegiate level, I remember I was recruiting into our School of Medicine, School of Nursing, School of Pharmacy. And the more research we did, the more I realized our students of color were systematically removed, sometimes because they didn't know how to write a well-written personal statement, that there's these unwritten rules that were systematically removing our students of color. Actually, we had a Native American student who had a 4.0, and she'd applied like 4 or 5 times and never got in. And I matched her with a mentor, and the mentor said, I can see why she doesn't get in. I said, why not? And she said, she has a terrible personal statement. And I thought, how is that the issue? If you think about it, because we're not systematically working with each other, we've created this barrier for no reason. I mean, honestly, the personal statement shouldn't be that important. But she said, I can tell. That's why she won't get in. We worked with her. She had a different personal statement. She gets in. So there are a lot of these barriers all along the ways, and we have to begin working as partners. At the university level, we need to really have partners at the high school level. High school level needs to have a partnership at the middle school level. And, we created a program when I was at the University of Colorado, and we identified there's certain classes, if you fail them, you are not going to get in. So we started tutoring to those classes, and that was disproportionately affecting our students of color. And so there are little places where we could be doing more work, but we haven't thought about a systematic solution. Everybody works in their own silos. At the hospitals, we need more diverse nurses, but they don't necessarily contact the local, nursing schools and say, hey, what are you doing? And what are the partnerships that we should be developing along the way? We look at the amount of debt you're going to take on, what are we doing at the hospital system to help alleviate the debt that they might take on? Like, there's so many different pieces. And I always tell people, if you have a systematic problem, you need to have a systematic solution. And we've talked about, systemic and institutionalized racism, but rarely do we have a systemic and institutionalized solution. And because everyone works in their individual silos, typically we stall, and people keep wondering, why are we stalling? And so we are going to have to take a step back, look at the system, and look at all the points where these barriers are created and remove those barriers. And oftentimes when we do that, people think, oh, that means we're lowering our standards. And I always think, maybe you have a standard that doesn't work. Mm-hmm. That's a more complicated question to ask is the standard even necessary? We were using this personal statement against the student who clearly showed they had the ability to do the job. They had all the necessary skills, and we were holding them up over a statement that we were systematically removing them. And then I even sat in some of the selection process, and I remember sometimes they would say, well, who's their letter from? So even the letter of recommendation superseded, if you had 2 students with 3.8s, it was what school did they go to and who was their letter of recommendation. They basically, in a way that they felt wasn't unfair, were institutionalizing privilege and racism. Because typically if you're a kid from an underserved school, you don't know that you need to have a recommendation from a certain person. You're probably less apt to get into the school, which will be respected. So even when you get your 3.8 and you put that 3.8 next to your peer, they don't take you because systematically we've put in these rules that remove you from this process, and really unnecessarily. And that's what makes people most uncomfortable, is when they have to look at themselves and say, what are the rules we've created that create barriers that aren't even necessary? And to me, that's where the solution lies, is that we have to have uncomfortable conversations. We have to look at, why are we selecting students in this manner? And in many cases, we even hold GPAs against students in ways, it's 10 years ago, and I still hold that GPA against me. Instead of saying, well, it's been 10 years, let's deal with who we have in front of us right now, which takes more work. But if we don't do that, we're going to continue to have the same problem.
Yeah.
I would agree with what Jason has said, and particularly at nursing schools, one of the things that I know that they may be looking at is the passage on the NCLEX exam. A lot of times, let's face it, there are certain cultures that have difficulty taking the standardized written test that other cultures may have no problem with. So they begin the weeding out process, if you will, in certain ways, because they want to make sure that they maintain a high passage rate on the NCLEX exam so that their program can continue and can continue to get funding. So instead of setting aside or actively recruiting minorities and maybe offering tutoring courses that would help them in the pre-nursing courses, before they get in, they automatically begin to shut them out, or they put in place a system whereby they fail. And here's a good example. You may pass a particular class, you may pass the final exam, but then sometimes they'll throw what they call a comprehensive final. And so even though you've passed all the courses and everything else, because you failed the comprehensive final, you don't get to, you don't get to go on. And, that is a huge stumbling block in a situation like that. Another one, somewhat like what Jason had suggested as well, is that we have these stumbling blocks. If you have a person of color who may be working as a nursing assistant, their life may be different from their white counterpart, who perhaps lives at home with mom and dad, whereas the other person is either living on their own, having to pay bills and et cetera. That's the reason they have to work. So it's, it's another stumbling block that they have to overcome to, work 8 or 12 hours, then come home, try to study, and then go to school as well. Whereas if a hospital were to put in a system whereby, we want to invest in this person, we're going to pay you to go to school, and you agree to come and work with us for, X amount of years once you graduate. To me, you're going to have in place a person who's loyally committed to your institution because they realize you invested in them. And so you're going to have a more loyal employee than someone who's going to, just take it as, oh, well, this is a job or perhaps an option of a job that I may have, as opposed to someone who wants to pay you back or thank you for, for making that huge investment in their career and in their employment after graduating school as well. So those are just some examples of how, we put those stumbling blocks in the way that we need to perhaps consider removing those.
We absolutely have to remove these stumbling blocks. And, Jason, you commented on, we have to have a systematic solution. And I think about the role that higher education plays in solving this important problem. Just a few weeks ago, I was looking at social media, and there was a leader from one of the top healthcare organizations in our country, very highly respected, great outcomes, exemplar for the industry. But he talked about, we have, 15% or 20% of our population that's African-American, but there's only 5% of the physicians that are African-American, and we can't solve this problem. And his point was like, we just cannot, because of that disparity. And that's where higher education, like he was saying, higher education has to step up in a big way. The nursing workforce of tomorrow is ultimately going to be determined by advancing equity in higher education. And we have to think about how to overcome the historically low underrepresentation of populations and enrolling in health profession schools and in learning environments, and the continuing dearth of proven and replicable practices and advancing diversity is really going to be a challenge. So, Dr. Jones-Schenk, I wanted to ask you, in recognizing that equity is the ultimate opportunity equalizer, how can we reinvigorate the promise of education for people of color? And what can institutions of higher learning do to eliminate these barriers and to allocate resources really to provide equity and access to learning?
Eric, I think this question is weighing on the minds of every dean of every health profession school in the country today. I was struck by what the AAMC said, and they said this, I quote, "Member institutions must be intentional in identifying exclusionary practices, critically deconstructing the practices that sustain inequities within our institutions, and acting to eliminate these inequities." So it's well said, but it's harder to do. As Jason pointed out, there are a lot of things that are packed in there, right? So we have admission criteria that's packed in there, and then we have biases of people on admission committees who want to know who wrote the letter, and we have a stacking of years of under support for education for fundamental sciences and math and the foundational skills that people need to move into the health professions. And so a lot of people are reaching this entry point without the preparation they need. And instead of recognizing that and turning course toward preparing and supplementing that knowledge and supporting those learners, you know, our history has been one of turning them away. So we have to set goals. We have to create supporting structures to advance those goals, including education and communication, as I said before. And we have to declare our commitment through action. So this means standing up and empowering groups who can identify structural issues that support racism from within our environments, and then resourcing their recommendations. So we've taken some early steps by asking our students and faculty and our alumni to raise up visibility on unjust or questionable practices in teaching and learning. We've started with textbooks and other learning resources, and we've been intentional and urgent in removing objectionable materials with haste. So that's a start. We've started analyzing our student success outcomes to see where inequity exists. And we need to keep digging until we uncover the root causes. As Jason said, they're so tightly packed in. It's easy to just skim over the top and not see where the real root cause is. All of these steps are entirely insufficient, but they are a start. And we need to keep digging, we need to keep unpacking, we need to keep raising the questions. And we have to address inequity and representation within the faculty and within our leadership in universities and in health professions, colleges. We need to be bold in setting goals and developing the structures. And then we need to feel uncomfortable. And we are feeling uncomfortable. In fact, we've had some difficult interactions already on this journey. And to me, that just says we are doing the right things. We are going to make some mistakes along the way, but we're going to keep being bold. And we're going to live with the discomfort as we find our way together forward with the vision in mind of reducing inequities in education, improving access, and ensuring that attainment is equitable, and opening opportunities to as many students as we can. That's our pledge.
Thank you, Dr. Jones-Schenk. And I wanted to expound upon this idea of inequities in education, because I really think it's important for our society to understand, like, okay, so health professions are committed, you know, across the world, across the country. There's system-wide approaches to creating meaningful change, and they're implementing quality standards. They're looking at cultural changes to improve upon fairness, and they're focused on eliminating these implicit biases that are really in teaching and learning. And it's, you know, really I've been identified as a root cause of outcome disparities in educational programs. And that's where I really wanted to, you know, explore this a little bit more. So there's these micro inequities that are subtle, they're unconscious, they're sometimes even unintentional. Didn't mean it to be there, didn't know it was there. But then because of that insertion of that implicit bias, it devalues the educational experience, and it discourages and impedes academic performance. And implicit bias and micro inequities have really been a challenge. But a lot of people out there may say, "Oh, come on, does that really exist? You know, someone's going to get scared off or get offended, and why are we even concerned about that? It's minutia. You're talking about, you know, changing a one sentence." And how is that really going to transform education? So I wanted to land on that topic with you in higher education. So Dr. Jones-Schenk, how can you provide some some insight rather, on how nursing programs should be thinking about eliminating this bias and learning, but also increasing awareness that it even exists, so that we can have more inclusive language with students and really redesign how assessments are conducted, so we can have a nursing workforce that truly, I think, can persist for generations and interact in a more socially conscious way, and we can remove barriers that are currently in place in higher education.
It's a critical question, Eric. I think the bias, as you stated, the challenge with bias and micro inequities is just how pervasive and invisible they are. They're invisible to many of us who've lived with the status quo so long. So for me, that means I need new eyes. I need new ways of seeing. I have to open the channels of discussion with people who can see these biases and micro inequities and who do experience them. I was stunned during one of our first faculty discovery sessions on this topic to hear faculty talk about teaching while Black and nursing while Black. These experiences I have never had. But as executive dean, I have a responsibility. No, I have an obligation to uncover the systems, practices, and processes and communications that create such experiences, and to the best of my ability to eliminate them. So I have to really reach out to my colleagues who have these experiences, who have this knowledge, who have this perspective, to help me see in new ways. And together we have to help our whole teams, our whole environment see in new ways. And we have to shun the some of the norms in society that say, oh, you're just being PC, or you're just trying to do the political correct thing. No, we're not. We're trying to correct long-standing errors in our culture. And so we have to be bold and willing to stand up to the detractors who say, you know, that's not really that big a deal. Well, if it manifests as an impact on a person, it is a big deal, and we have to be ready to stand up to that. You know, we're doing a bunch of things across the university. We're a competency-based university, and so we rely heavily on our centralized assessment processes. They're a division within the university, and they've already taken a huge intervention across all of our assessments to begin an initiative to analyze item differentiation as it relates to populations of learners. So they're taking this very seriously, because they know that there are micro inequities and bias in assessment, as Dr. Grant pointed out earlier, in our national exams, which are very much based on psychometrics, but are those psychometrics considering population-specific differential analysis? I think there's a lot of work that can be done there. So until you see it, you can't change it. Mm-hmm. And once you see it, hopefully you can't unsee it. Mm-hmm. So will higher ed be able to make the changes? I don't see it as a choice. Mm-hmm. I was gratified yesterday to see that 39 health systems across the nation declared racism a public health crisis, mm-hmm. and committed to address healthcare disparities across the nation. They've made a real strong commitment. They've said they're going to make their hiring efforts inclusive. They're going to improve access for COVID testing in underserved communities. I mean, they came out with a list of things that they are going to do, including increasing spending with diverse-owned vendors and suppliers. And so we are suppliers of the workforce to those healthcare systems. We must also make some pledges. And I would say a good place to start is the recent Macy Foundation report on addressing harmful bias and eliminating discrimination in health professions learning environments. And there are 4 recommendations that I'm going to just share with you, because I think this is a pledge that we in higher ed for the health professions could make and should make. Number 1, develop systems to assess and address the current state of bias and discrimination throughout the institution. So really a root cause analysis. What is the current state? Number 2, reduction of harmful bias and discrimination as an institutional priority. So that speaks to resources, communication, structures. Number 3, comprehensive curricular offerings throughout the institution explicitly aimed at reducing harmful bias and discrimination. So directly speaks to what our curricula are doing, are bringing forward, both in terms of social justice, as well as you know, the tradition, the more traditional cognitive focuses that our curricula has had. Number 4, increased representation of underrepresented backgrounds in trainee, faculty, and leadership positions. And finally, create an institutional culture of respect, inclusion, and equity for all members. So these are big pledges. These are important steps to take, and I just would encourage us as a higher ed community to come together on these recommendations and to be bold in stating our commitments.
Well said, Dr. Jones-Schenk. And, you know, I see that we're going to end this panel today 15 minutes after the hour. So we have about 10 minutes for questions. So I'm going to pose one more question to Dr. Grant. For our attendees out there, if you have any questions, please put those in the Q&A box, and we'll go ahead and take a few of those questions. But just one last question for the panel before I go to audience questions. Dr. Grant, you know, I want to think about, you know, just as we conclude our conversation today, how to catalyze change. And I think that's going to come about in the nursing profession if we really mobilize in a united way around addressing and eliminating healthcare disparities. Can you speak to what ANA is doing to empower nurses, both socially and economically, to create meaningful change within healthcare organizations, higher education institutions, and also the political arena?
Certainly. Most recently during our 2020 membership assembly, just in June, we passed or adopted a resolution on racial justice and for communities of color. And it reaffirms ANA's position against racism, discrimination, and healthcare disparities. And some of the things that it pledges to do was to oppose and address all forms of racism and discrimination, condemn brutality of law enforcement and all acts of violence, and in partnership with nurses everywhere, educate, advocate, and collaborate to end systemic racism, particularly within nursing itself. Again, taking what Dr. Jones-Schenk said, and looking inward first, and then working outward for that. Also, advocate for the ending of health inequalities in communities and healthcare systems that stem from systemic racism, and then promote deliberate and respectful dialogue to effective listening. I think that's one thing that we probably haven't listed today, but just to really listen to what is going on, and then be committed to change what you have found out from listening along those aspects. I'd like to also just point out one other quick thing from a financial perspective as well. Our philanthropic arm, the American Nurses Foundation, just completed a financial impact survey on nurses as a result of COVID, and we found that there are financial hardships of nurses were facing because of the pandemic, but it affected more the Black and Hispanic and Latino nurses than their white counterparts, especially when it came to accessing savings or stopping payments on student loans or borrowing from friends and family, or even seeking assistance, such as charity, like going to a food bank, things that you wouldn't think that, that nurses would do. So by educating nurses, we're going to about the importance of financial management is another aspect that will go as well. And we have a webinar on our website that helps to address that particular issue also. So there's a lot that ANA is trying to do, and of course trying to get nurses more politically active, letting them know that they have a voice and they have a vote. And there's 4.3 million registered nurses out there. That's a pretty powerful voting block. And if we all do vote, doesn't matter what party it is that you vote for, but the mere fact that you are voting to help drive change is extremely important as well.
Thank you, Dr. Grant. I don't see any questions from the audience, but please, if you have any, feel free to type those in to the Q&A box or even in the chat window. We'll go ahead and monitor that. But, I guess as we look to wrap things up, and again, we have, just about 5 minutes, Jason, I wanted to go ahead and, transition back to you. If you could provide some concluding commentary, as higher education, healthcare, and society partner together, we have this uncomfortable conversation, and call it for what it is. We have racism. We must deal with it. Obviously, there's probably not as much public condemnation as we would like. I think there's even some some concern, or some awareness that's been raised from the presidential debate the other night. But can you provide, just some parting comments, like how can we partner together in a meaningful way to really come up with solutions for this very important problem?
Yeah, I wish I had that answer. If I'm that good, I would probably be busy with work all the time. I think it's a fair question, though. There are things we have to do, and one of it is we need to own ourselves. A lot of times we think, oh, it's too big, but if each of us understood the data, and we all have a sphere of influence, there are moments in time where we can make change, and I would suggest every nurse has that moment every day, where we can make sure that the care I'm delivering is the care that is appropriate for that patient. And if all of us took on that onus, we could make change, because each of us are responsible to it. We call it health disparities. That is actually behavior each one of us. Each one of us are contributing to that in some way. So if each of us were to say, you know what, I read a little bit and try to make sure I think about what I'm doing every day, and am I treating all the patients with the care that they deserve? Or is it sometimes I'm rushed and I move past some rooms faster than others? Those things make us uncomfortable, but we've got to stay in that space. And if each of us made that commitment, I do think we could make change. Because if you think about it, it is the summation of all our individual behaviors that creates health disparities. So if each of us make commitment, we could actually reduce health disparities by being very intentional and staying in an uncomfortable place.
Very well said. And, I'd love to have this conversation again. I think we have to be able to overcome this important problem. One question we just had come in from the audience. Isn't there a way to add mandatory diversity training? I guess maybe there's a question there around, is it effective? I mean, we can make it mandatory. Can any of you provide some perspective on that? This might be our last question today, but we might be able to take another one, but I wanted to at least present that as an audience question.
Yes, yeah, so as somebody who does a lot of diversity training, I would say it's not mandatory training, it's consistent, regular training. The reason mandatory training doesn't work is you train people once and the assumption is it fixes it forever, and it doesn't. And what we need to have is every month or every week or whatever, you need to continue to have these conversations, because issues around race are complicated and issues around health disparities can be complicated. And so people need to be reminded on a regular basis. That's how you get the change. If you want people's change in their behavior, you have to remind them all the time and make them conscious of these challenges that we face as an organization or as a system.
I would also say, add to that, that the word mandatory already throws up a wall, a brick wall, so that the person may not be receptive, even though they recognize it as a problem, but because they're being told you have to do this, or you have to attend this course, they may not be as receptive as if it were not going on constantly, and consistently, and being re-evaluated periodically as well.
Well, and we think about, in nursing, we think about the mandatories, right? Fire and safety, HIPAA, all the mandatory trainings. And I think the word mandatory has gotten kind of a bad rap in the sense that it's really about continuous improvement and, training that helps us to be better oriented to the requirements of our interaction in the world. I mean, whether it's sexual harassment training, whether it's racial bias training, whatever that form that training may take, I would like to see us get rid of the word mandatory, because I agree with you, Dr. Grant. It's like, okay, or we're just going to get the stick out and make you be there. And I kind of wonder how that sets us up to learn.
It's a great point. So I guess I don't see any other questions coming in from the audience, but a lot of great comments. I wanted to thank you all on our panel today. I think we had a wonderful discussion, and hopefully, I believe through this dialogue, we can create some meaningful change. I would love to have this conversation and then really go maybe have a part two, where we could have more, solutions and thinking. But for our listeners out there, this webinar is being recorded. We will have this on the Race to Value podcast. Please check out the podcast. This is a podcast that was recently launched by the Accountable Care Learning Collaborative that has the biggest thought leaders in the industry. And this is a problem, institutional racism. It is a problem in health value. We have to solve it. And I think it's going to come through partnership between higher education. It's going to come with the industry as well as our society. And again, thank you for our panelists today. I just think we had a really important conversation, and and I appreciate everyone from joining us today.
Thank you, Eric.
Thank you, Eric.
Thank you.